Good afternoon, everyone. I'm Elena Thomas from Medico Marketing team. Welcome each one of you on behalf of Brinton Pharmaceuticals for AcneScar webinar. It is our honor and privilege to have with us esteemed doctors, mentors, and dignitaries from national and international for this webinar. During this webinar, we will be exploring various aspects of acne scar, its phases, management, and treatment modalities. Our session will be interactive and engaging, allowing you to actively participate and ask questions and connect with the fellow attendees. We hope that you will find this webinar informative, thought provoking, and inspiring. Now I hand over the PPT and to Swapan sir. He is a BU head for the Brinton's perspective. Over to you, Swapan sir.
Thank you, Alina. Good afternoon, Doctor. It's my distinct honor and pleasure to extend a warm welcome to each one of you to this esteemed gathering of brilliant minds. Today, we are privileged to have remarkable faculties and delegates like you with us. Before moving ahead, I want to share a small and but vibrant journey of Brinton Pharmaceutical. Brinton incepted in the year 2013 and within a started commercial operation in year 2014. Within a year, Brinton Pharmaceutical become number one and fastest growing company in IPM and with growing with a CAGR of 52%. Moved to top 100 ranking among 132 companies launched in the same period of 2014. This is one of the fastest growing company, Brinton Pharmaceutical. In this small journey, Brinton has gathered many awards and applauds. This award serves as a testament to our unwavering commitment toward innovation, quality product, and patient satisfaction. Because of your trust, faith, and support, the Luliconazole brand of Brinton got AWAC awards in 2018, and the Ubidu, the number one sunscreen brand today in Indian pharmaceutical market. So with this small introduction or small sharing about Brinton Pharmaceutical, I want to restrict myself and I will request Alina again to introduce our moderator and to move ahead with the session. Alina, over to you.
It's our honor to introduce our esteemed chairperson and moderator, Dr. D.J. Saple, which is having a 40 years of medical professional renowned with expertise in the field of dermatology, venereology, and lepology. He has made a significant contribution into the medical community, particularly in the area of HIV/AIDS research and treatment in India. Doctor has an impressive educational background, including a fellowship at prestigious Johns Hopkins University in Bloomberg, USA. He has served as the honorary professor and the head of the Department of Dermatology, Venereology, and Leprology at Grant Medical College and JJ Group of Hospitals in Mumbai. Throughout his career, has associated with several renowned hospitals in Mumbai, including Breach Candy Hospital, Esther Rahija Hospital, and Fortis. He has also provided expert consultation in the field of dermatology and leprology. Doctor has actively involved in training future medical professionals, serving as a trainer for the fellowship program in HIV/AIDS under the Association of Dermatologists, Venereologists, and Leprologists. He has also held esteemed position as the president of IIGVL and the College of Physicians and in Mumbai. Sir has served on the editorial boards of various publications, including IIGVL, as well as the Indian Journal of Dermatology. He has contributed to medical literature with over 50 peer reviewed publications and chapters in the medical textbooks. Sir has expertise and knowledge have been sought after both nationally and internationally. He has delivered over 1,270 lectures across the country
I think
and presented at
I think Alina, I think you are taking too much time. I think we can cut it short.
Moving to the awards and recognition, Sir has received the Lifetime Achievement Award conferred by IMA in 2017 in Mumbai, as well as the Breast Practitioner Award at Dermacon International Congress 2019. So, welcome, sir, for this webinar. And now over to you.
Okay, thank you, Alina, and thank you, Brinton, for organizing such a nice webinar on acne scar. And of course, this is a very important subject. The reason being, now all of us we are aware that the patient coming to our OPD, skin OPD, the spectrum is changing. That previously, if you ask me, we used to see cases of scabies, bacterial infection, STD, leprosy. That was when we were students and we started practicing. That was the spectrum in our OPD. But now everything is changing in last 8-9 years, and most of the patients they are coming to our clinics, either they are pigmentation, hair loss, acne, or the cosmetic. So that's why I'm thanking Brinton for organizing such a important event or the webinar on acne scar, which is the need of hour. Now for this we have speaker. Yeah, Dr. Sweta. Sweta is dermatology and aesthetic physician and founder chief of the chief and Hydra Dermatology Chennai. She is practicing the government medical college and private practice. And the important thing about her, she is a gold medalist and practicing more than 15 years. So we'll have Sweta as a speaker. She'll talk about the acne scar, about the basic things and the management. After that, we'll open it, after her talk, we'll open it for discussion from the panel discussion and answer from the panelist and the questions from the audience. So I'll request Sweta, please go ahead with your talk.
Thank you, sir. That was a very nice introduction. Welcome to everybody for this August occasion with all the August members that we've had for the discussion. So can you see my slides? Are you able to see the slide?
No. Yeah. Slides are not seen, huh?
Just 1 minute. It will take half a second to 1 minute.
Okay, anyway, we have got very good panelists. I think I'll introduce panelists. First panelist is, I think, Swagat has joined.
So can you see the slides now, sir?
Yeah. Okay, yes. You go ahead. Then we'll introduce panelists before we start our discussion. Yeah.
So a very good afternoon to everybody. I'm Dr. Shweta Rahul. Today we will be talking everything about acne scars. I'll try and make my presentation as short and crisp as possible. So as we all know, acne is one of the most prevalent skin diseases occurring in more than 80% of the adolescents, 50 to 60% of women aged 20 to 25 years, and 12% of women over 25.
Shweta, you can go for the slideshow. This is on the slideshow.
No, it's not on the slideshow, sir. I'll change it as I'm talking, sir.
Okay, yeah, okay, no problem.
Sure, yeah. So acne scars is the main issue with acne, and it has a variety of issues, including low self-worth, psychosocial issues, and a negative impact on the quality of life. Whether it's about going for an interview in college or it's about marriage, acne scar comes in the way of all issues. So a scar, by definition, is the fibrous tissue that replaces normal tissue destroyed by injury or disease. An acne scar is a permanent textural or change or an indentation that occurs on the skin as a result of severe acne. Now, there can be two types of acne scar formation. One, as we know, is the hyperplastic scar due to an increased tissue formation, giving rise to the hypertrophic scar and the keloid. Now, this forms a very small percentage of the acne scars, only around 15 to 20%. The other side is the atrophic scar due to the loss or damage of tissue. These can be divided into ice pick, rolling, and box scars. So, as far as the acne scar is concerned, until and unless we know the stages of the scar formation, we will not know where to intervene and where to hit the scar the most. So the acne scar formation happens in three stages. The first is the inflammatory phase, where the immune cells surround the pilosebaceous unit and produce inflammatory proteins. Now, these inflammatory proteins cause the surrounding blood vessels to dilate, resulting in redness. This is the reason for post-acne erythema and hyperpigmentation. So whenever you see post-acne erythema or hyperpigmentation, it is to be noted that there is inflammation going on right beneath. The proliferative phase or the healing phase is the next phase where the cells become active to produce structural proteins such as collagen and keratin that build the skin structure again in that area. The third phase is the remodeling phase or the cleanup phase where there is a resynthesis of the extracellular matrix. This is the phase which decides what type of scar eventually forms in that area. The acne lesions with more extensive inflammation leave scars when they heal, while those with less inflammation often heal without scarring. Too much collagen breakdown at this point leads to atrophic scars, while excessive production of new collagen results in a hypertrophic or keloidal scar. Now, this is a pictorial representation of how the phases of scar formation are. The first phase that you see, the coagulation or the inflammatory phase, starts from minutes of the acne formation until a few hours to days later. Now, here you have the neutrophils which come from hours to within 5 days. After 5 days, the monocytes or the macrophage play the major role in removal of the bacteria, necrotic tissue, phagocytosis of the pathogens, cell debris, and further secretion of growth factors. The second phase or the tissue formation phase lasts for weeks after. Here, the interplay is between the keratinocytes, the myofibroblasts, and the endothelial cells in reepithelializing, ECM formation, and angiogenesis along with MMP production. The third phase or the remodeling phase is the most important thing, which goes on for months already. So this is the phase that decides whether your scar is going to be a normal scar or a hypertrophic scar or a keloidal scar, depending on the kind of collagen that is formed, the way that it's cross-linked, and whether they are thick or thin fibers. So going forward, the acne scar morphological classification is divided into two. One are the elevated scars, which is again divided into the hypertrophic and the keloidal scar. Raised scars caused by the collagen deposition within or beyond the borders of the original injury represent these type of scars. This is a smaller percentage of the scars as such, 15 to 20% at the most, but the majority of the acne scars are atrophic scars. They are divided into, as we all know, ice pick, box, and rolling. Now, the ice pick scars are typically deep and narrow, with the apex larger than the base, sharply demarcated tracts that extend to the deep dermis. The box scars, in turn, are again divided into shallow and deep scars. The shallow are less than 0.5 mm in depth, and the deep ones are more than 0.5 mm in depth. Round to oval depressions, anywhere between 1.5 to 4 mm in diameter, with sharply demarcated edges, vertical edges, and they are flat bottomed. The wider rolling scars, as such, are more than 4 to 5 mm in diameter, shallow or deep depressions with gently sloping edges, which are generally caused by the fibrosis of the dermal tethering. Now, Goodman classifies the acne scars as macular, mild, moderate, and severe. Macular scars are generally erythematous, hyper or hypopigmented flat marks. They do not represent a problem of contour, but of color. Now, the mild scar, a mild atrophy or a hypertrophy that may not be obvious at a social distance of 50 centimeter or greater, and is generally able to be covered up by makeup or by a thin beard. The moderate scars are those which are obvious at social distances of 50 centimeter or greater. They are not easily covered up by makeup or a beard. But the only thing is, when you're in the case of an atrophic moderate scar, when you're stretching the skin, it generally becomes less visible. The severe scars are those which are evident at social distances. Secondly, not covered by makeup, not covered by a beard, and even if you stretch the skin, they are not going to be able to become lesser. Goodman and Barron also had a quantitative scar scale. Depending on the number of lesions of each type, they decided whether it's mild, moderate, severe, hyperplastic papillar or hyperplastic keloidal or hypertrophic scars. Moving on to the management of acne scars. So, why do some people scar more than the rest? This is a very, very interesting topic in that the severity of the inflammatory acne. I mean, we would have all noticed in practice that it is not just the inflammatory acne, but there is a bit of disparity between the type of acne and the amount of scarring. So why does this really happen? As far as the acne severity is concerned, generally the inflammatory acne scars more, but this does not mean that the superficial acne doesn't scar. The time between the onset of the acne and the onset of effective treatment, any delay in this will mean that the scarring is more. So we have to be very, very efficient and aggressive in treating acne and not wait for it to develop into a more inflammatory phase. The third important point, and in fact, a very interesting point, happens to be that the P. acnes phyllotype makes a difference. You know how? Because the P. acnes phyllotype, the different phyllotypes, differentially activate the epidermal innate immunity, contributing to variations in the acne severity. So the type of P. acnes determines how severe an acne can be. In patients not prone to scarring, the early lesions have a large non-specific immune response that subsides in the resolving lesions. Whereas in patients who are prone to scarring, the early lesions are characterized by a smaller number of skin-homing CD4 plus T cells compared to the non-scarring patients. So this response becomes more active in the resolving lesions. So the people who scar have a more specific CD4 plus T cell that is there in the resolving scar, causing further and further formation of scarring as such. Now, other than this, relapsing acne, male gender, truncal localization, family history of acne, ethnicity, sun exposure, and frequent severe acne breakouts all are factors which determine how severe the scar is. The family history is of importance because if you're going to have a parent bringing a child for acne treatment, you need to look at the parent's face. If the parent is having scarring, you definitely need to be a little more aggressive in treating the acne on the child to make sure that they don't end up with severe scarring themselves. Now, the one thing is treating the scars after they are formed. But how do you actually prevent scars even with your treatment of acne? So, the first thing is early treatment of active acne remains the best way to prevent or limit acne scarring. Acne scarring, as we all know, doesn't happen only with the severe ones, but even can happen with superficial forms of acne. Once you have treated the acne early, as inflammation starts very early in the course of the acne itself, active maintenance therapy for acne serves a very, very important preventive therapeutic role. The third thing is a long-term maintenance therapy controls both visible and subclinical inflammation and would be expected to reduce both the acne lesions and the acne scarring over time. So what I generally would say is that start aggressively treating acne early on. Once you have, I've seen people who, practitioners who stop isotretinoin at 2 months, 3 months. But then again, the patient is going to come back and say the acne has come back. So what you can do is whatever it is that the anti-inflammatory treatment that you're, initially starting on, make sure that it continues on over for a period of 6 to 9 months or a year. After that, I generally give a combination of, benzoyl peroxide and adapalene as the active maintenance therapy for them to continue using over the next 1 year to have a long-term maintenance with an active agent. So this really helps to keep the acne at bay because they're always coming back with questions of, doctor, can you give me a permanent solution? Which is not possible, but what you can best do is give them a good maintenance. Now, an important point here is that the abnormal changes in elastic fibers and collagen fibers are found in the early developmental process of acne in patients who are prone to atrophic scarring. And an early treatment regimen that strongly inhibits inflammation and the TGF-beta-1 signaling to help the normal recovery of the ECM is required to prevent the atrophic scarring. These are the things we can do even while treating the acne to make sure that the scars don't happen later on. Treatment of the acne scar itself. So what should you really do? The first treatment starts with managing the erythema first. That's the first component that we address. Moving forth, once you have done that, we address the atrophic scarring next. Combination treatment is always a much better thing than having 1 or 2 treatments to give the patient a better benefit on the scar treatment. Now, topical treatments of scar, invariably, we do have many methods, but then the ones which have been constantly studied include tretinoin 0.05, adapalene 0.3, tazarotene 0.1, and a combination of adapalene 0.3 and benzoyl peroxide 2.5. All these reduce the inflammatory cascade early on by reducing the innate immunity to the P. acnes. They also decrease the synthesis of MMPs, increase the dermal procollagen and the collagen synthesis. So there is a better remodeling and less of the fibrotic scar production. Antimicrobials like benzoyl peroxide and minocycline act by being anti-inflammatory. Your topical corticosteroid, we all know, we use it time and again to reduce inflammation in the cystic nodules. Tacrolimus happens to be a very good agent to reduce the topical erythema, as far as the scar-associated erythema is concerned. How? Because number one, it inhibits the T cells and so it's anti-inflammatory. Secondly, it reduces DEGF, hence reduces the scar erythema that way. Vitamin C is also found to be pretty good, especially used with iontophoresis. Now, 15% glycolic acid is also a good choice. If we had to go for treatment of scars, invariably you would choose a stronger percent of glycolic in clinic. But when you're going for a home use regimen that the patient can use as a topical, a 15% glycolic used regularly by the patient seems to also have some benefit. Tranilast is an anti-allergic drug given as a mast cell inhibitor. So this also seems to have an anti-inflammatory effect in the topical treatment of scarring. Now, I'm not going to go through all of this, but these are the various combination topical treatments which have been under study. What I found interesting somewhere out there. AFMSC is the amniotic fluid mesenchymal stem cells. They've also tried topical insulin with microneedling. That seems to have an effect in the scar pathways to bring down the collagen production. So these are the various combinations tried. Now, a word about the scar-associated erythema. Now, this is a problem that all of us face time and again. The fair patients with the erythema which doesn't settle at all. Both the PIH or the post-inflammatory hyperpigmentation and the post-inflammatory erythema present grossly visible and histological notable inflammation. This is of point because constantly there is inflammation, which means you have to act early to bring down the inflammation if you want to bring down the scarring later. So the interesting point here is that this may be related, the inflammation may be related partially to a slow degradation of the non-viable P. acnes within the follicle. Maybe this is where the minocycline and the anti-inflammatory, antibacterial agents also give you an anti-inflammatory help there. The post-inflammatory erythema results not only from this inflammation, but also from the wound healing related microvascular dilatation, and which is exacerbated by the repair related epidermal thinning. So there are so many factors which are associated with the erythema that's going on. Medically, what do we do about this? Oxymetazoline helps. Brimonidine helps. Tacrolimus, pimecrolimus, especially tacrolimus given helps quite a bit. Of course, the moisturizers and the sunscreens really do add a great value to your prescription. Tranexamic acid to a certain extent topically and maybe orally also helps. Procedurally, we have the PDL laser, we have the KTP, which is a double switch mode in the Q-switched NDI. IPL also helps. Now, apart from all this, I mean, these lasers as such, everybody doesn't have the bandwidth to have all these lasers with them. But I find that even microneedling started early does help bring down the erythema fast enough because of the collagen remodeling and the growth factor production. Okay, now as far as the topical treatment of the acne scars with different sheeting gels, hydrocolloid dressings are concerned, these are the various ingredients which have been studied. I'm just going to leave you with this slide for a second so that you can go through it. We have silicone, we have onion extract, we have mitomycin, imiquimod, green tea, aloe vera, and vitamin E. Let's see how each of it acts. As far as the silicone gel is concerned, that and the vitamin E both act on the dryness of the scar. They give it hydration, moisturizing, soothing, anti-inflammatory, hence improve the scar appearance. Aloe vera helps with the itch. Green tea is an anti-inflammatory agent, reduces the mast cells and inhibits the pathways necessary for collagen synthesis and brings down the collagen synthesis. Now, onion extract, mitomycin C, imiquimod, verapamil, all of these decrease the fibrosis and the excess proliferation of ECM. They bring down the stiffness of scar in each way themselves, right? So all of this gives you basically a good scar remodeling and a better moisturization of the scar and hence reduction in the scar itself. Coming to the physical resurfacing or the surgical treatments. So you have an acne scar, patient with an acne scar, how would you really approach it? First would, as I said, let's see if there is an erythema. If there is a component of erythema, treat it with your vascular lasers or with your topicals like what I said, then move on to the atrophic scars. First decide what is the majority of the scar. Is it ice pick majority, box scar, rolling, or is it a combination of all three? Now, there are multiple modalities such as these to treat the atrophic scars. There are the chemical-based agents, multiple chemical peels which are used. The TCA cross, botulinum toxin is also used as injections around the scar to reduce the pull of the muscle on the scar. Laser and energy-based devices, you have the microneedling radiofrequency. Among the ablative and non-ablative lasers, I think the most used are the fractional carbon dioxide and the fractional erbium YAG. Now, conventional surgical therapies, including subcision and the punch excision or the punch elevation, all these are also included in the treatment. Controlled mechanical trauma are the dermabrasion, microdermabrasion, microneedling, and the jet volumetric reduction. I'll talk to you about the JVR later. Cell-based such as PRP, GFC injections, leukocyte-rich plasma. Other than that, fat and filler-based. So you can either use temporary or permanent fillers. I'll also talk to you about the biostimulatory fillers, which have become the latest hoo-ha in US. I'll talk to you about that later. Okay. So if you are looking at a patient, how do you really pick the modality? If you have a majority of ice pick scars, what really works with the ice pick scars? The cross or the chemical reconstruction of scars is the best technique for ice pick. Other than that, punch excision also works with ice pick. The other things you can do which work moderately well are the fractional, ablative, and non-ablative lasers, including the fractional carbon dioxide or the fractional erbium YAG. Now, if you're having more of rolling scars, then you need to first consider subcision. Other things which also help, including the fractional erbium or the fractional carbon dioxide. Fillers also help, whether it's going to be fillers with fat or with PRP or GFC or your hyaluronic acid fillers, that's for you to decide later. As far as the shallow box scars are concerned, see, generally with box scars, your punch elevation helps. If it's a deep box scar, punch excision. Other than that, your MNRF, your fractional CO2, and your erbium glass, all of it helps. Microneedling, PRP injections, all of these help. So how would you combine different modalities for the win? If you're a person who has a non-energy based practice, you don't have the bandwidth or you don't have, for whatever reasons, too many lasers, how would you really manage these scars? As far as box scars are concerned, these are the combinations that you can do either in a single sitting or in multiple sittings to deal with them. Microneedling, TCA, 15 to 20% or maybe even more, punch elevation, PRP or GFC injections, autologous fat transfer, fillers. So this is the bunch of things to do for the box scar. As far as ice pick is concerned, microneedling, cross, TCA, punch elevation or excision, PRP and GFC injections. Rolling scars, you can start with the subcision, microneedling added on, PRP and GFC injections added on, fillers whenever you need to do it, autologous fat transfers. This is for non-energy based clinics. Going forth, if you have the bandwidth to have the energy-based devices, then you can go with it this way. For box scars, go with microneedling radiofrequency, fractional carbon dioxide or erbium lasers, punch elevation PRP. Ice pick, you can go with microneedling radiofrequency, fractional CO2 erbium 1550, punch elevation or excision PRP in different combinations. Rolling scars, subcision, microneedling radiofrequency, PRP or GFC, fractional CO2 and erbium. Now, the final mix of all this is mixing the combination of the non-energy as well as the energy-based devices for the best results. Now, some random thoughts for practice. Now, clinicians may encounter, they sat down and had a board of maybe I think around 5-10 years back. They decided to call scars hybrid scars. Why? Because mostly we encounter both atrophic and pigmented scars. So we are always, do we call it a atrophic scar? Do we call it a pigmented scar? These should be termed as hybrid scars. Now, patients undergoing fractional therapy or even for MNRF, they should be advised that you can have an acne flare-up. One thing I do in practice to prevent an acne flare-up is be very diligent about comedone extraction every time the patient comes, whatever be the procedure, whether it's for laser toning, whether it's for MNRF, CO2, whatever it is, make sure that the comedones are extracted before the patient leaves. I find this very, very helpful to prevent acne flare-up. Now, TCA cross, if done, should be a standalone therapy. Now, if you're going to include a laser in the same sitting, you have to allow the TCA to set, which means you have to let it some time, give the patient half an hour, 1 hour before you go in for the laser, because the moisture which is generated by the fractional and ablative lasers can dilute or spread the effect of TCA beyond the desired margins and onto a freshly lasered skin, and that will give you unnecessary side effects. The one interesting thing that I read was the biostimulatory filler. Now, Bellafill is a dermal filler, which is a combination of bovine collagen, 80%, with a non-resorbable PMMA and 0.3% lidocaine. These are biostimulatory because they not only volumize instantly, but also continue to evolve the scar with production of collagen. If you give a single injection, it's said to last for more than 5 years. In fact, after 8 to 10 years, the patient is supposed to feel very good about themselves. The only hitch is that it's a bovine collagen injection, and they are asked to wait for 28 days after every test dose to make sure there is no allergy to bovine collagen. Also, it is prohibitively expensive. We don't have it right now in India, but in the States and any other European countries, it is available. Okay, so a clinical trial, I'm not going to bore you with clinical trials. All they have said in all these trials is that combining PRP with a fractional carbon dioxide and derma roller works better than doing just the fractional or just the derma roller. That's basically the crux of all these slides. The newer treatment approaches, we have the autologous non-cultured dermal cell suspension. You have the autologous fibroblast culture. I'll just run you through this. The autologous non-cultured dermal cell suspension is a preparation of an autologous, the same thing, the dermal cell suspension by incubating a de-epithelialized dermal biopsy with collagenase. Then it's injected to correct the fat loss, I mean the facial volume loss rather, the dermal atrophy loss, not the fat loss, sorry. The autologous fibroblast culture is cultured fibroblasts, which are again used to fill the gaps. Jet volumetric, this was a new term to me, I've never heard about it, but then apparently it's a needle-free proprietary technology which delivers kinetic energy and healing compound, whatever it is the compound you're using at a high speed, which actually are like tiny bullets, nano bullets, which pierce and disperse in the dermis to create microtrauma, which eventually causes neocollagenogenesis. They've been using hyaluronic acid to treat the acne scars that way. Radio frequency substitution, a lot of these are not, I wouldn't say a lot. One of the company which offers MNRF also has a radio frequency substitution probe, and I found it very interesting because then you have less of hematoma and less of bleeding when you're doing the substitution as such. You can go a little deeper when you're doing it. Yes, so that's the end of a small. I still have a little more to go. Please don't leave. Okay. So I'm just going to tell you a few things from a bunch of photos from my patients and how I dealt with the, with the acne scarring. The thing is, I burned my hands with fractional carbon dioxide a few times because I didn't have the machine and I used to rent it out. So hence, I stopped using the fractional carbon dioxide for a couple of years in between. Instead, I have a really good Q-switch laser and I started using the fractional mode in the Q-switch for acne scars and they seem to work beautifully. Now I have bought a better CO2 app with an erbium YAG together. So I don't have too many pictures of the fractional carbon dioxide and the erbium YAG, but I do have a lot of other pictures. Using even the Q-switch machine, what we need to do is use what we have to the maximum possible extent in every combination to get good results. So, like I said, a good Q-switch can work wonders. The first case is a patient of post-acne PIH of maybe 6 months old. So she was very, very worried about her PIH. Although this photo, the one on the right, looks like it's got a bit of a thing. When we take it on the phone, it adds a little filter, but then it is quite accurate how the patient looked in person. So if you see, this was a lead PIH, and this is 4 sessions of laser toning, 1 month gap. She's done very well. Right. So the next patient happens to be a patient of severe acne and PIH, moderate scarring, obese, polycystic ovarian syndrome. 4 sessions of, this was a difficult case because she was obese, she was refusing any kind of treatment. So 4 sessions of laser toning. So now all these patients, this patient was on isotretinoin. I am a large user of isotretinoin. She was on isotretinoin and aldactone along with the laser toning sessions. So 4 sessions of laser toning. This is where I use the fractional mode, which beautifully works like microneedling. Just like microneedling, it just gives you jets of microneedling shots of the laser itself. So these are the pictures. Next patient is a severe scarring, 2-year-old scars. MNRF gives the message is that MNRF gives good results, but fractional resurfacing is a must after the MNRF for better results. Combining procedures is very important. She did not come further for the fractional though. This is just the MNRF results. Fairly good. I wouldn't say it's bad, but then it could do even better. Now, this is what I was talking about. For erythematous scars, if you don't have a PDL, you don't have a KTP laser, you don't have an IPL, you can still do with microneedling, radiofrequency, or just microneedling. Now, if you see, this is still an erythematous, it was actually a lot more erythematous in person. A lot of erythematous scars. This is just microneedling, just 3 sessions of microneedling. All the scars have come down. This patient is again a patient of erythema with the acne scars. 2 sessions of microneedling, isotretinoin, tacrolimus, good sunscreen. Good improvement. You can see that most of the erythema has subsided. The other one is grade 4 acne with moderate scarring. What was done was black peel. I always start with comedone extraction and a salicylic or a black peel. That is my first go-to step. Comedone extraction, I think, is the most important game changer. Something as basic as taking all the pustules and the comedones out, give wonderful results very, very quickly for the patient. So there was a black peel done and then a little bit of ILS and then 3 MNRF sessions. And that's the result at the end of it. Young chap. You can see a lot of comedones, pustules, and so on. He's still under treatment. I'm shifting him into the fractional carbon dioxide now. I mean, or maybe the erbium YAG. Now, this patient is a PCOS with grade 2 acne with both PIH as well as post-inflammatory erythema. Now, this is 4 sessions of MNRF with yellow peel. For people who don't have a Q-switch, you can still combine 2 modalities. The yellow peel, what I feel, 2 important points take home here is that number 1, it reduces the number of comedones and the active acne flare-up later, not the comedones, rather the active acne flare-up later after the procedure. Secondly, it also helps with the pigmentation part of things. See, it's almost a good reduction of erythema and the pigmentation. But sometimes the journey is long, but the results are worth it. This is a patient of severe acne scarring. She was so distressed because she didn't want to go to office. She didn't want to, they were looking out for marriage for her and it just wasn't happening. So this is after 5 sessions, first 1 session of salicylic acid peel, a good comedone extraction, 5 sessions of laser toning for the pigmentation, and then 4 sessions of MNRF. And today she is doing pretty well. Now, another case of grade 3 to 4 acne, hirsutism, PCOS, moderate scarring. First, as usual, I start with a comedone extraction with the SA peel in the same session, and then 5 laser tonings and 3 MNRF. In fact, she's getting married this month. And if you can see the hair, she's also been undergoing laser hair removal. I have a long pulse. I also have a triple wavelength, but for her, because she was also undergoing the the Q-switch laser toning, we used to do the hair removal in the long pulse itself. It's the same machine. Now, like I was saying, the Q-switch lasers also have a fractional mode, which we don't really use too much. We never really go that way at all because we're always using the Q-switch mode normally. But this also gives you a very good result because there's minimal downtime. There is nothing like, no downtime like a fractional as such. Obviously, the results cannot be compared to a fractional. It's more comparable to an MNRF or maybe a little better. But treatment of both the PIH and the atrophic scar in the same session is possible. It's more cost effective for the patient. So we should explore full spectrum of the lasers we own. This, for instance, laser toning with just the fractional, a little bit of, the Q switched, but a lot of the fractional mode itself. Very good results with this. So this is a case of just 1 sitting of a comedone extraction with a peel and isotretinoin, just 1 sitting. Just to give an example of how you don't really need. Yes, sir. Yes, sir. Yes, sir.
How long you'll take it because we have to keep time for the discussion.
2 more, sir. 2 more minutes, sir. That's about it. I'm done. Okay. Yeah. So this patient is just a peel with isotretinoin. That's about it.
Yes, good.
Same patient. That's about it, sir. I'm done. Okay. Thank you so much. Okay.
Okay. Thank you, Sweta. You really covered very well, including the basic, giving some punches also, how to manage it, and you have made it very easy. Of course, when you are giving the talk, it is a little bit in a hurry. So now we are opening for the debate or the panel discussion. So can I have a slide of panelists? And then we'll take questions from the panelist. Anyway, if there are no slides, I can read it. We have 3 more panelists. One is Dr. Shubha Ksri. Dr. Shubha Ksri. She is a dermatologist, venereal leprologist, and the medical director of Naipunya Aesthetic Clinic, Bangalore. She is very much interested in laser and aesthetic dermatology. She is good for the acne scar discussion. Of course, she has got many awards and many publications. So we'll go for the next panelist. Yeah, next slide, please. Yeah, Dr. Saugata Thambe from Mumbai. We have to congratulate her because she has become head of the department. Head of the department, and the first time she got the DNB students under her. She is very much interested in clinical dermatology, dermatosurgery, and dermatopathology, and of course in aesthetic medicine also. The next one, next panelist, Manoj. Manoj is comparatively the younger person, but he is assistant professor in IMS and some hospital, an ex-senior resident from AIIMS. Manoj is very much interested in vitiligo, immunoglobulin disorder, psoriasis, and so on. So now all 3 panelists are there. So we'll start with. I think Alina, if there are questions, there are some questions. Let me know. For the audience, questions from the audience.
Yes, sir. The question is from the doctor Punshi, that does sun produce acne scar and how?
Yeah, I think I'll ask this first question to Dr. Saugata. Saugata, can you audience?
Hello.
Yeah, how the ultraviolet rays are responsible for the acne scar? Yeah.
So they are not responsible directly for acne scar, but definitely they are responsible for more aging in the acne scar, because as we know, sun exposure is one of the factor for aging. And in acne scar, we can see if we see the surrounding skin and acne scar, if we compare, then the aging will be more prominent in the acne scars. So therefore, sun protection should be one of the treatment modalities when we are managing patients with acne scar. But they are not directly responsible for causing acne scar, but they can definitely make it worsen. Even hyperpigmentation can be more evident if the patient is exposed to the sun and they are not using sunscreens.
But you would like to use sunscreen in each and every patient or selected patient?
So like in acne scar, we talk about the management of acne scar, but sometimes it is in our hand to prevent acne scars also. Like as madam said, we can, use isotretinoin and all. We can do comedone extractions and early treatment of acne. That is expecting that these people are going to develop severe acne scar, manage them early in the time. And from the medical management, whatever isotretinoin antibiotics we are giving orally, we can also use moisturizers and sunscreen as a supportive treatment. And this may not directly improve the acne, but yes, they have a role to play in the management prevention of acne scar.
Scar formation. Okay. Thank you, Saugata. Alina, is there next question?
Sir, the question asked by Dr. Sanjay, can we combine NDYA and CO2 for scars?
Can you combine CO2 and
NDYAG?
Okay, so I'll ask Dr. Shubha.
So we can combine the Q-switched NDAC laser and the fractional CO2 laser. I prefer to use the Q-switched NDAC for a little pigmented acne scars and fractional CO2 for all kinds of scars, rolling scars, box scar. And I have a machine which has a dermal toning mode with the Q-switched NDAC, which I often use along with the pigmentary mode for taking care of the scars. But I don't combine the Q-switched NDAC and the fractional CO2 in the same sitting. But I do it on different sittings.
Yeah. Okay. Thank you, Shubha. Other panelists who want to add to this combination of NDAC and CO2, fractional CO2, or you?
Sir, can I just add a word to that, sir?
Yeah.
I think if the machine has a fractional mode, using that also really helps in the same sitting to reduce the atrophic scars to a certain extent, sir. But I would agree with Dr. Shubha. I think invariably patients want treatment of the pigmented scar first, and then they're really not as bothered about the atrophic scars. So yeah, on different sessions, sir.
Yeah. Okay. Thank you. We'll go for the next question.
As Dr. Kirutika has raised, it is MNRF with yellow peel at same sitting.
Yellow peel?
Yeah.
MNRF with yellow peel at same sitting.
Okay, I think I'll ask Dr. Manoj. Dr. Manoj, you are there?
Yes, sir. Yes, sir.
Yeah, please. Yeah.
So, sir, for my case, I have never used a yellow peel. I've more used a black peel and salimandelic peel or plain salicylic acid peels. And I feel those can be combined with MNRF or a plain derma roller. But for plain yellow peel, I have not been through the experience of that. For salicylic acid peel, obviously, after the peel, salicylic acid peel, I have tried all the procedures we have done, even fractional CO2 after giving a sali peel. And obviously MNRF is a good option. I have not personally used MNRF, but derma roller and all, we do it after a sali peel or a black peel.
I think, what about the other panelists? Anybody wants to contribute?
Yeah, can I just add to that, sir? Because I think it was from my slide that they even asked the question. So generally, after doing the microneedling, MNRF, either one of these, the yellow peel is a seal-in mode. You seal it in and send the patient home and ask them to wash it off after 4 to 6 hours in the same sitting. And it is really helpful.
Okay. Okay. Thank you. We'll go for the next question.
The question asked by Dr. Azaiba, how to avoid risk of PIH post-fractional laser?
Okay, that's a very good question. I think again, I'll start with Swagata.
So again, is this patient, if we see there is a lot of hyperpigmentation on the face post acne PIH is more, we normally should not directly go for the laser treatment. The same way we prepare the patient for the peel, we should use lightening agents, proper use of sunscreen. If there is a dryness on the face, moisturizer, it's like a preparing a patient for fractional CO2 laser, just like the way we prepare the patient for the peel. So this is like anticipating this patient may develop PIH. Look at the, this is more I'm talking about the skin of a color, or if the patient have more severe PIH, that is a time you should not directly go for the procedure. I think we can use the lightening agents, hydroquinone, tretinoin, and then we can prepare the patient, we can reduce the hyperpigmentation, and then we can go. That is the one way we can prevent it. We can also use the chemical peels before we start with the fractional CO2 laser. And as Madam rightly said that it's if we see all three phases, we see acne, we see PIH, we see scars, and people are always they are always want the treatment of all three together. So I normally counsel the patient in that way that first we have to treat the acne, then PIH, and then we will go for the scars. So if we do it sequentially, the chances of hyperpigmentation are very less.
Correct. Thank you, Swagata.
So can I just can I just add to that, sir? Sir, another way, I completely agree with what Madam said. But the other thing is, when we are planning for the fractional lasers, by reducing the density of the dots, or rather between 2 points of the fractional, make the distance between the, you'll have the parameter on the laser, increase the density between the decrease the density and make the distance between the dots in the fractional more, and increase the depth as such, the penetration depth while you're in your setting, to prevent PIH. This would be the ideal thing to prevent PIH, especially in dark skin patients or in otherwise also.
Yeah, thank you. But then, you know, the basic things, most of the patient, if there is a history of atopy, you know, hypersensitivity, that many times we do not ask this history. And these are the patients, they are likely to land up into post-inflammatory hyperpigmentation. That is very common, and somehow we in a hurry or we are too much busy, we do not ask this. But as Swagata said, and as another panelist said, we have to be very careful, prepare it, counsel the patient, and then go ahead. But my experience next question, Alina.
Is that how to use MNRF and yellow peel together? Which 𝐄𝐯 laser is good?
Okay. Yeah, Dr. Shubha.
So you can do, as Dr. Shweta told, we can do our passes of MNRF, then use the yellow peel as a sealant and ask them to wash off after 6 to 8 hours. So I don't use the yellow peel, but I do microneedling and fractional CO2 laser in the same session, giving a small gap with adequate priming and preparing of the skin. Very strict advice about sunscreen use. And I also use a mild topical steroid to prevent PIH. This is one of the ways that I deal with, preventing PIH. And I use my fractional CO2 parameters as, a little differently. When I'm combining it with microneedling, I don't do retinol peel with microneedling. And 𝐄𝐯 ∞, there are a lot of good machines in the market. Any machine is good when you learn how to use it and you get comfortable, you play around with the parameters, and most of the machines you can master it and use it to your advantage. But always choose a good sturdy machine and ask your colleagues who've used it before buying that machine.
I think I entirely agree with Shubha that it comes by experience. We have to learn it, and once you start using, you'll come to know what are the problems and how you can use it. But at the same time, one of the things about these machines, everybody comes and promises you, but if they post delivery or once they sell machine to you, their service is very important. Many times once they sell the machine and they do not bother. So this is the message for the new people. any company is giving good service, just find out from the market. I'll suggest that company's machines will be better. That is one of the things, not all the time. I think we'll go for the next question, Alina.
It is from Dr. Satyashil. It's like a cesarean scar short therapy, better fast result.
Pardon, can you repeat it?
Cesarean scar. It is regarding the cesarean scar short therapy.
Yes, okay. I think Manoj, you want to take it?
Yes, sir. For the
About
cesarean scars, I have gone through like most of the cesarean scars are around 30 to 40% of these scars have a hypertrophic component.
Yes,
so
correct.
That part is normally managed with either a cryotherapy or intralesional corticosteroids. Sometimes I use silicone gel sheets also if the patient is affordable. Otherwise, we go for only intralesional corticosteroids and cryotherapy.
Yeah, I entirely agree with you. Usually there are hypertrophic scars unless there is a history of keloid. But Manoj, how long it takes to subside?
Sir, in my experience, the ones which I have treated, it takes at least 6 to 9 sessions, sir. The earliest I've seen is by 4 sessions, but normally I say at least 6 sessions a patient should be counseled, because otherwise they hope that within 1 or 2 sessions they have 100% improvement. But that's tough.
That's why this question is a longer duration, but it works. Hypertrophic scar, if they come early, it works very well. Almost all the scars can disappear and they become invisible. So we'll go for the next question. Yeah.
Dermapen 9 needle and 36 needle, when to use?
I think this question goes to Swagata. Number of needles.
So I have not used Dermapen too much, like number 9 needles I have never used. I normally use the 36, 42 number of needles, but it is a good replacement for a derma roller, and I am not very sure where they use 9 number needles. I normally use 36 and 40.
I think we'll ask Shweta.
Sir, actually, there are also, I generally use the 36 one for the scalp, sir, because in South Indian skin type, there is too much of PIH coming after Dermapen, generally was what I found. So I tend to use the one with the 12 pin, which are available for the face, and use the 36 ones for the scalp, for the PRP, basically.
So, yeah. Shubha, you want to add?
No, sir, I don't use the Dermapen, so I would not know, to be very honest.
Even I don't use the Dermapen. I use it only for PRP.
No, the question is why do not use it?
Because we have the MNRF, that's why.
I like my MNRF. I've had it for almost 8 years now,
so
and I just love the device.
Easily available and giving good results, so no need of that, correct?
Yes.
Yeah, I think. Yeah, so we'll go for the next question.
Which is the best treatment to avoid these scars?
Okay, that Shweta has already mentioned, but again I'm asking Shweta.
Yes, sir.
As for any basic thing, the treatment of any disease or any problem is a prevention, correct?
Yes, sir, absolutely.
So how you are going to prevent any patient? Most of the patients of acne come to you. What is your advice to them how to prevent scar? That is a basic question and very good question.
Sir, you mean tell the patient the basic care instructions, such as don't pick on your skin, don't expose to the sun, stop, change your diet, lifestyle, the usual set of things that we tell them. But the first thing is to do a comedone extraction and start them on anti-inflammatory agents. At that very point is that if you stop the inflammation, you prevent the scarring.
I think I entirely agree with one of the point that comedone extraction, is a very important point, because many times people do not have time. So because the extraction you have to do very skillfully and it is quite time consuming. I think many doctors are trying to avoid, because that's what I learned. Whatever the patient comes to our clinic, we ask that basic question. So I entirely agree. Comedone extract is the basic things. Yeah. So we'll go for the next question, Alina.
Is there an endpoint for treatment of acne scars? Like this is the maximum result or that is impossible? Dr. Shiva Shankari.
I hope this is not the a questions like the end question, like an end point, no? anyway, I'll ask Shubha.
So actually, that's very individual, I guess. You will have a set of patients who will be very happy with a kind of improvement that you may not be too happy about, but there will be one set of patients who will not be happy even though you are extremely happy about the results that you have given. So it should be between the doctor and the patient that they should discuss. But you are, with the available modalities of treatment, it depends on whether you are doing a laser-based treatment or a non-laser based treatment. So you look at the degree of and the grades of scar. So you look at the degree of improvement, and depending on the grade of the scar, if there is anything between like a 40 to 70% improvement and the patient is happy, then you can, if the patient is happy, then there is no need to go ahead with it.
Yeah, but other panelists, because this is important,
I think everybody can just comment on it.
I think 100% improvement that we cannot always, guarantee to the patient.
Never.
That, and we should not aim at that also. Patient satisfaction should be the end point. I think depending on what we can offer, because after a period of time, even we see the improvement has plateaued, and we cannot further see. And as our grading of acne scar says that how much we perceive it when we have a close encounter, that I think should be the end point. So patient satisfaction, and obviously our assessment of 70 to 80% improvement, and we can maintain the patients later on anti-scar agents or tretinoin, whatever is feasible for the patient. So I think that should be the, we should not expect 100% everything becoming completely the normal. It may happen in some patients, but that is not the expectation in all patients.
Yeah. So is MNRF better than microneedling?
Do you want to, shall I take that up?
Yeah,
yes,
please.
Yes.
All right. Definitely better than microneedling. MNRF is definitely better. It's an energy-based device. It's going to give you the microneedling along with an energy of RF right in there. Definitely better collagen synthesis. Alida, you can go on to the next question. Yeah.
Move to the next question.
Just
Okay.
about
Keep moving. Keep moving.
Yeah,
I think
Manoj
sir
sir
will
want
also
to add
want us to
something.
proceed.
Yes, sir, please.
No. Actually, I wanted to ask ma'am, how much difference do you feel? Because I have never been through an MNRF machine. For my setup, we have more into micro needling. So, how much different does it happen between the micro needling and MNRF?
So I used to use the microneedling and derma roller initially quite a bit, right? And they do definitely, there is merit to that particular modality because it gives you improvement, no doubt, absolutely no doubt. But even compared to that, when you're adding another energy-based device to that, it's definitely better because obviously in terms of energy, you're also giving energy, you're also doing microneedling. See, also because you can also vary depths in an MNRF, which you cannot do on a derma roller. Or you can do it with a derma pen, yes. With a derma roller, you can't do it. A derma pen, you can still do it. But when you're giving energy at so many depths, definitely it has a better, collagen synthesis versus just the microneedling alone.
Thank you.
And also the number of sessions you require, that is also less with microneedling radio frequency.
True.
Shall I move to next question?
Yes, please do.
Yes.
Post CO2 laser patients are complaining of acne dryness. So how to go ahead? Need to know about epidurophate gel 0.3%, which is available in the market.
I think Saple sir has joined.
Yeah, no, go ahead with this because sorry for that.
Shall I repeat the question again?
To that question because that question is very important. What is the end point and what we should be done, because the procedure we cannot continue lifelong, no, or the longer time. So Swagata, what you do, you start the procedure, after some time you have to discontinue.
Yes, sir. I think we have answered that question, sir. You were.
Oh, sorry. Yeah. Okay, then. Okay, all of question because this is a very important. Manoj?
Yes,
Sir, my case, I always counsel my patients that I cannot get more than 80 to 90% improvement. My endpoint is only 80%.
Yeah, okay. The procedure, once you are done the procedure, when you are going to stop the procedure, Shubha?
Sir, usually I tell them that they need to be patient. They are in for the long haul. And after finishing about 4-5 sessions of microneedling, that itself takes 4-5 months. Then I do my PRP injections if I deem that it will help. Then sometimes 1 or 2, then I even suggest, filler
Yeah,
treatment.
but somewhere you are...
So, yeah, maybe, 1 year into treatment, I see reasonable improvement of around even 65 to 70%. And I feel that I have done my best with all different. I should have the confidence that I have used different modalities to treat all the different kind of scars they have. And I cannot give more than that. Patient is satisfied. Then I just stop it, sir. I tell them that this is the best and we can probably review a little later.
I think I'll go back to Sweta.
Yes, sir.
Because...
Yes, sir. Please. So this is for the same question, sir?
You already mentioned your talk. You started talk with that and you ended talk with that.
Yes, sir.
You were talking about the maintenance therapy, correct?
Absolutely, sir.
Yeah, so can you elaborate on that?
Yes, sir. So generally, I am a very extensive user of isotretinoin. So initially, for the first 3 to 4 months, I put the patients on 20 mg 5 days a week to 6 days a week, sir. I always give them a weekend break because I feel the patient does better with it. After that, for the next 4 months, they are on 4 days a week. After that, for the next 10 weeks, they are on 3 days a week. At this point, they've already had isotretinoin for the first 6 to 9 months, sir. After this, if I feel like there are no more breakouts coming out, I change them into adapalene and benzoyl peroxide combination on a 4 days a week, alternating with a lightening cream or so on. So this I feel is the active maintenance topical therapy. I tell them to continue it on for a period of 6 months. So this is the way that I generally deal with it, sir.
Yeah, so topical therapy, that's why I'm coming to that. In topical therapy, the scar as a maintenance, you have to continue for a long time. Do you agree with me?
Yes, sir.
Once your all procedure are over, so which combination would like to use it?
Tretinoin, sir.
Pardon?
Tretinoin, sir. That's the most.
Tretinoid, any other, or you want to have a formula with
with the silicone gel also, sir. That also is quite good.
Tretinoid, in anything else?
I use tretinoin and then 3-4 days a week tretinoin. Then I sometimes use glycolic acid as well.
Yeah, that's also a good molecule, definitely.
No other. So which formula will prefer? What is available in the
market?
Means our clinical practice.
0.025 to 0.05% depending on the skin type. How thick and seborrheic the skin is, I just use, and sometimes not even a daily treatment. It can be like 2 or 3 days a week.
Okay, so you have to maintain with the retinol and the glycolic. And Swagata, what about you?
So just the question she
along
asked
with that,
that after sometimes what happens when you are doing too many procedures, patients do get the sensitivity of the face, dryness. These are some of the consequences of doing multiple treatments. And patients also sometimes don't use moisturizer, sunscreen as we advise. So I've seen few patients who after doing fractional CO2 laser come with the dryness of the skin. That is a persistent dryness. They feel that their skin has changed from a completely oily skin to a dry skin. So these are some of the consequences. So as Dr. Shubha said, we don't use maintenance therapy more on a daily basis, and that depends on patient's individual requirement. We can use it as a twice a week therapy with a continuation of sunscreen, moisturizer, depending on what type of skin patient has at that point of time, at the end of all the procedures. But maintenance treatment definitely has a role to play. And even for scars, post-procedure hyperpigmentation, anything is left, we can use that.
Yeah, so that topical treatment has to be continued for long. That is the... Manoj, you want to add any other component in that, or?
In my maintenance therapy, sir, I normally give them a therapy like whenever there is a breakout, they use it for 10 days. Then they stop it. till they get any new breakouts, because for a continuous maintenance it is a
No,
cumbersome therapy for
we
the
are
patient.
talking about the scar here more than the treatment of acne. Scar maintenance. Once
Scar
you
maintenance, I mean, normally I don't prefer silicone gel based things, because I have throughout the days I have seen it is only effective if it is a hypertrophic scar. It's not very useful when there are atrophic scars. Like there
yeah
are new modalities where they say the silicone gel causes improvement in these atrophic scars, but in clinical practice I have not seen any improvement. So I only advise them for the hypertrophic scars. For the
yeah
atrophic scars, as ma'am told, I advise them they can go for tretinoin around 5 days per week, then 3 days per week, and then stop it off. Most of the times I see hardly some 10-20% improvement, but in the maintenance phase I think topicals have very less role. I don't feel it has much role. They have very little
okay.
role.
I think I'll ask raise all four panelists that would like to continue topical or not. Manoj is not in favor. What about other three panelists? Topical treatment for the scar once the procedure is over.
Sir, if
Or
they're getting, if they, when we use topical tretinoin, then it also acts as an anti-acne management. So if it is a younger individual who has got their scars treated, who is not actively having acne, but younger age and acne prone skin, then I would ask them to continue to use it. And it has good anti-aging benefits as well, but it all depends on the patients. For some people, they're happy and they don't want to maintain it, that's also fine, but a sunscreen and a that would be mandatory, not necessarily a scar management. Sunscreen and probably hydration, and treat the acne if it erupts again. But for those who are not very happy, who still want more, then I just ask them to continue the tretinoin and give it time, so that there will be a little more improvement over a period of time.
Shweta?
Sir, actually, what happens in the for practical scenario is when the patient has completed the therapy for scars and they're okay, they're fairly happy, or they're feeling better about themselves. They start looking at all the OTC formulations. They're ready to ask the next question: when can I use niacinamide? When can I use all the fancy OTC serums? They're just waiting to use all of it. So I generally give tretinoin maybe for 2 to 3 months. Then I give them a little more bandwidth to use all the fancy molecules, sir. The niacinamide and the all the other hyaluronic and niacinamide and all of that. I start including that in because they want some more rather than the regular tretinoin. So generally, I don't go forward and use it for more than 3 to 4 months after the scar reduction, if they are happy already with the procedural improvement.
I agree with this psychological problem that you have to treat the patient more than treating what is the clinical problem, because you have to treat the whole. So they need something to be continued. But our experience in my clinic, usually we continue topical for quite long. We ask them to continue once you treat, because they are also happy. Only as Swagata has said, we'll have combinations of everything, moisturizer, sunscreen, all everything should be there. Just giving retinol is not enough, just giving sunscreen is not enough. So we have to give, they're also happy. But most of the time patient, they come, the scars is a combination. You do not get particular one type of scar. So how you are going to manage those patients? Because always scar is in the combination. No, they are not going to come that I have got only ice pick scar, I have got this box scar.
So I think we choose a modality which is commonly working for everything, sir. Because if you take ice pick, box, and let's say mostly they are usually a combination of ice pick and box. Commonly, that's what we see the most. If this is the combination between the two, invariably the microneedling radiofrequency works, fractional carbon dioxide or erbium works, and also a bit of PRP or GFC injections work. Just within a combination of these three, you can address most of it. So I think we should find the common modality, sir, which works for most of the other scars.
Yeah, so ultimately we have to give the combinations, okay? Yeah. So now any message you want to give for acne scar? I'll start with Manoj. Manoj, what is your message in treating acne scar?
For me, sir, I feel that no single treatment is best for acne scar. always combination is good. The older modalities are still have a very good place. Like I feel subcision has a very good role, and TCA cross has a very good role in the treatment of acne scars. Though I use fractional CO2 and erbium YAG here also, but I always have I have seen that whenever there are more rolling scars or box scars, one or two sessions of substitution and then going on to the lasers gives better results than directly starting with the lasers. This has been my personal experience. So a combination of the conventional modality and the latest modalities, with along with a counseling of the good counseling of the patient, that it takes time for the remodeling to occur for 6 months to a year. So that would be the best part for management of acne from my side.
Okay, thank you, Manoj. Now, Shubha, what is your message?
A similar one, sir. Basically, combination modalities will work. We'll have to counsel the patients, align their expectations, learn from them what their expectations are, and the best combination treatment. And also align them that it is going to take some time to show response, and they should not be expecting dramatic or drastic results. And I do believe in giving a little bit of maintenance for at least 6 months after their procedural interventions have stopped, because that helps in preventing a relapse of the active acne, creating new scars and things like that.
Yeah, good. Thank you. Now, Sweta.
Yes, sir. Sir, I agree with what everybody else said, sir. The most important thing I'd like to give as a message is always take pre and post pictures, because once the acne scars resolve, the patient has no idea how they looked before. So that is the only way we can save ourselves, sir. After so many sessions, they'll come back and say, I see no difference at all. So I sit them down and tell them, this is your pre, this is your post, and with full depth. And on the image, I will show them each aspect of the scar. Then only they are satisfied. So pre and post images are very important. So that's the message I'd like to say. I mean, everything else I already said on my slides, that there's nothing more to say.
Yeah, you have made it. Yeah. Swagata.
Sir, as we know, there are multiple methods we have, multiple modalities of treatment. We always make an individualized approach. Like if we see more of a rolling scar, then subcision is the first session we go for. If you are seeing more of ice peak scars, then we consider doing cross TCA with MNRF. And definitely MNRF, microneedling, fractional CO2, they still remain the mainstay of all. During the procedural treatment, we need them. Any of these modalities, they really improve the outcome of the scar management. But definitely, if we have more of a rolling scar, then we can go for the subcision, 1 or 2 sessions of subcision. And we can also use cross TCA for if the patient is having multiple ice pick scars. That is, it is for some patients who have a particular scars more. A particular type of scar is more in those patients. So then we have a straight way to go ahead. Otherwise, most of the time we have to combine all the procedures. And again, taking a photograph is most important, because it happens that most of the time patients say there's only mild improvement or little bit of improvement. When they see the photographs at every session, also you yourself can compare and choose or change the modality. It happens that sometimes after using it for many number of patients, some modalities doesn't work, just like our drugs. So we can change it. We can change the modalities and shift to the other treatment modality if we ourselves find that there is no improvement happening.
Thank you. I think, basically I'm a HIV clinician. We also started the cosmetic clinic. And what I learned, first thing, as all of you said, the combination treatment works. Only any single treatment is not enough. Number 2, as you have mentioned, counseling plays the major part about the disease progress, the outcome of the progress. And thirdly, what is important, that when you start treating the disease, treat the disease, maintain it, and prevent it. If follow all these 3, definitely will be also satisfied, patient will be also happy. And I think, Alina, is there any important questions? Otherwise, I can hand over to you.
Sir, Dr. Nagpure want to share something.
Last question.
Okay, yeah.
One last question, sir.
Yeah.
Yes, sir. Yes, Nagpur, sir.
Yeah, Nagpure, sir.
Hello.
Yes, sir.
Yes,
sir.
My point is, what age you take all these procedures? Because acne is the one which can go until the age of 30 years. what are the chances of recurrence?
No,
Due to
in
all these
other
questions,
way, if Dr. Nagpur comes for the treatment for the scar, how you are going to handle it? Am I right, Dr. Nagpur?
I come at the age of 20, but again I'll get the recurrence at the age of 30. Then what happens?
Okay. I think, yeah. Please go ahead. Sweta, we'll start with Sweta.
Yes, sir. So ideally, starting early always gives an advantage, sir. So at the point of the remodeling of the scar, which is why the minute I control the acne, which is usually a month or month and a half, I start with the scar revision immediately. As far as the age of the patient is concerned, we definitely see that the 20s and the 30s have a better collagen remodeling, better results with the scar. But even then, some patients have really surprised me. I have done a derma roller, just microneedling, over a 67-year-old patient for chickenpox scars of 40-year duration. Beautiful response. So I think it's very individualized, genetically how we produce collagen and how our scars remodel. So I would say never for anybody if they want to do scar reduction. But obviously the results are much lesser as the decades progress on because the collagen also doesn't form as well. Sir.
Shubha, you want to add?
Yes, I agree with Dr. Shweta. And generally, very bad inflammatory acne with a potential for scarring, I generally start them on isotretinoin, and after a good control and maintenance, isotretinoin is when I start them on scar treatment. So fortunately, most of them at least have not had a recurrence of such bad inflammatory acne that they required, scar treatment. But there have been instances wherein 5-6 years later, they've had a very bad episode and I've had to repeat their scar revision as well. So it is individualized, but if we treat the acne very well, control it, and then start the scar revision modalities and continue little bit maintenance, tell them to address their acne, then there is hopefully no need to keep doing the scar treatment again and again.
So you believe in prevention, correct? Once everything is settled.
Yes.
No.
Especially after they've spent a lot of money, spent a lot of time, you would ask them to be very vigilant and prevent the acne. And patients are also aligned by that time. They don't want to go through that entire thing again. So they do treat their acne and they do take care.
I think Swagata, you are practicing next to Dr. Nagpur now. You got to answer.
She's away from me. I won't mind sending all the patients to her.
Start sending all these patients to me.
Anyway, this is a good question. I'll just share my experience. Dr. Nagpur, one of the celebrities, she came to me. She is 85. She had a few hair on her scalp. She said, my granddaughter is getting married. I want a hair as 85. And I'll show you a photograph. She got such a beautiful hair. So as Sweta says, don't say no to anybody. Always try and you may succeed. I think I'll hand over to Alina.
How did you get the hair so fast?
Yeah, for that, Dr. Nagpur, you have to come under training. There is a training in my center. You come, I'll give you training, not free. You have to pay for it.
Okay.
I'm just joking, huh?
Yeah, I know.
I think I'll hand over to Alina now. And thank you. Thank
sir,
you, panelists. Thank you all
sir,
audience.
Thank you so
sir,
much.
there is one question which is bothering. Sir, one more question which is bothering. Like, when this acne scar treatment should be started? After the acne or during the acne itself? Like, first you treat the acne, then you start treating the acne, or during the time of acne only you start treating the acne scar?
Sweta, can you finish this question?
Yes, sir. So generally, when we see the stages of the scar formation, it is at the remodeling stage, but you should have started treating the inflammatory component, which is the first stage. That is what you need to aim at. That's what you're doing when you're treating the acne. When you want to start remodeling the scars, treat it as soon as the acne subsides. Immediately, you start your remodeling of scar, which is usually in the a month, or it starts after 6 weeks to 2 months of the active acne itself. So when you do that, the remodeling is best addressed at that point.
I think other panelists you want to add to this, just adding sentence. Anybody?
Sir, I always, after 1 month of control of acne, I start with acne scar treatment, sir. At least 1 month gap, because this is the ideal time where remodeling, the granulation tissue has formed and it has gone into the remodeling phase. So that is the best period where you should do the action. And if it is a mild scar, at that time, fractional CO2 works wonders.
I think according to Swagata, it depends upon the individual, no? Person to person, correct?
But sir, if we start early, we end up getting very good results. Especially the patient ask us what percentage of improvement we can expect. So when we start early, the improvement can go up to 90%, 100% also, especially for the milder scars. And if we start little late, the improvement get, because as you said, sometimes we get patients coming after 20-30 years of acne scarring, and then they decide to take treatment. So there we have to counsel that the improvement may become little lesser in them. But yes, if we start early, immediately after resolution of acne, the improvement is very good.
Okay, thank you. Shubha?
I'm sorry, sir, I missed the question.
Pardon?
I missed the question, sir. I'm sorry. I just lost this one for some time.
No, the scar treatment should be continue with the treatment of acne, active acne, or first you treat the active acne and then go for the scar treatment?
I would treat the active acne, and once that has subsided almost, as early as possible, start the scar treatment, because that's when the scar treatment works the best, sir.
Yeah, so consensus is as early as possible, that I think everybody has agreed. So Alina, now I think you can take over, or still you want to? I think please take over.
Sir, it's up.
Yeah. Yeah.
Okay. So there are other 2-3 questions are there. So should I take it, or?
I think
I think we will put it in the group, and then we will get the answers from all our
analysts will answer, because they'll be. I entirely agree with the audience. I'm very, very happy they are taking so much interest, but I think there is a limit where we have to stop it. Otherwise, I think Brinton has to arrange the bigger program.
Yeah.
This is an indication. Yeah.
Sure, sir. Yeah, Lina.
And you should be working on.
So now I request Gopesh sir to take forward, so that he would be sharing a brief regarding the.
Sir, I take just 1 minute apart from giving the vote of thanks. Is about the results which we have got with our one of the formulation in AcneScar. As you all have suggested us that AcneScar is one of the treatment which is difficult to treat. We have come up with a formulation with LMCPA and silicone, and which has given excellent results. We have done one PMS study. I just want to share this slide where 55 centers, 435 patients it has been tried, and the results are 76% reduction in acne depth has been noted. Erythema is up to reduce up to 77%. Acne diameter has been reduced to 76%, and acne scar pigmentation has been reduced up to 79%. If we look at the patient happiness index, 85% patient felt happy and confident in 90 days. Of course, this treatment, this study has been conducted. In some of the patient, it has been done with procedure. Some of the patient, it has been done without procedure. At the same time, almost 11% of the doctors have used this with isotretinoin, and rest of the doctors have used it without isotretinoin. So we will also share this detail with all the doctors. So apart from this, I am really delighted to be a part of this session, which has been moderated by Saple sir. Saple sir, thank you very much for accepting our request, and we look forward for many more active participation with Brinton to make such scientific program a big success. I thank Dr. Shweta Rahul for giving us a lot of insight about acne scar management. At the same time, I thank our panelists, Dr. Shubha Kesri, Dr. Manoj Kumar Nayak, and Swagata Tambe madam, for giving all the answer, which has lasted for more than 45 minutes, and giving all the clarity. I am sure that this webinar will help many more patients and many more doctors to have a faster recovery when it comes to the acne scar. We are going to share this webinar to almost 8,000 dermatologists with whom we are being connected through either WhatsApp or email ID. Thank you very much to my team, Alina, Rahul, and my backend team for making this program successful. Thank you very much. Thank you again, all the respected doctors who have attended this program.
Okay, thank you. Thank you, everybody.
Thank you so much.
Thank you, sir.
Brinton,
Nice meeting you.
Thank you, sir. Thank you, Dr. Safle.
Thank you. Thank you.
Thank you.
Thank you.
Thank
Sir.
you.
Thank you, sir.